Good morning, everybody. Thank you for coming back after coffee. I hope you had a nice break. So we have an interesting session now with two speakers who are going to talk to us about their lessons learned regarding revision surgery. It's my pleasure to introduce my friend and colleague Saeed, who's from the wrong side of the Pennines, from my respect, but in Manchester. And he has a huge experience of revision surgery, both in adult and paediatric world. I'll hand you over to Saeed.
Thank you so much. When I was asked to talk on this subject, I thought long and hard. And the more I thought about it, the more difficult the task appeared to me, because there is so much I want to say, and there is so much that has gone under this bridge, which I would like to impart. I started collecting material, and I think I had 500 slides or so, but I think Mr. Verma tried to persuade me into reducing the number. So I'll do my best, try and get some themes across. Revision, lumbar and thoracic spinal surgery. How big is the size of the problem? Where, if you are the patient, either you haven't got it and you've got away with the first surgery, or you have it. The numbers really don't matter too much. I think the figures that are bandied about, I think they are an underestimate rather than an overestimation. In Salford, it's a reasonable size unit, and we do a fair number of complex revision cases. The revision cases we do often come from other units, and it gives us an insight as to what is going on, and it allows us to look deeper. We all know these points. I don't need to go through them individually, but what is most important is the patient at the end of it. And what comes out of it, if you have to have a revision, is often multiple revisions, and these can lead to a life-changing event for the patient. So the patient may go away disappointed, and perhaps sometimes worse than what they came in with. The magnitude of the problem may be bigger than the initial problem itself. So trying to analyze and try to work out, what is it that goes wrong? What is it that we can learn? And I think we can work on all of these points. Some points are easier to tackle than others, and I think that the top list, patient-specific, we all know these, and with adequate planning, we can try and reduce the risk, and perhaps sometimes even avoid surgery or modify surgery, depending on what the problem is. The bottom point, I think, is particularly important to me, and that'll come through the talk. I think it's important to take your patient through this journey, and it is a journey. And the patient really needs to understand, and you need to appreciate that the patient has understood what this journey entails, and potentially what could go wrong, and what that would mean for the patient, who may be in a comfortable position in a job that they're doing, but they are not happy with their symptoms for one reason or another. So they need to know what would happen to them if you didn't do the surgery, and what could happen to them, and what the implications are for the surgery that they would have. And then there is the unknown, okay, the unexpected. And this is, and we need to put all of those things together. We talk about outcomes from specific surgical procedures or conditions. I think we need to be looking into what causes failure, and this itself is a mammoth task, but it is a task that we really do need to undertake and to take seriously. So what I'll try and do is to go through some challenges that I've come across, and try and give some benefit of experience from our unit and our take on this. talking about thoracolumbar, I'll start from the bottom. I think if there's one message I can give, and I can walk away at this moment and I will have done justice, is that whatever surgery you do, when you do a fusion surgery, there will be a consequence. No matter what, there will be a consequence, and it will bear fruit at some stage. And that's just the nature of the beast. The longer the fusion, the bigger the cost. That's a basic formula. We do know about it. In situ fusions, appreciating the rhythm and the global nature and how the spine is really important to understand. In situ fusions result in problems earlier than they would otherwise. Spondylolytic spondylolisthesis is a common one that keeps on occurring with adjacent level or two level above problem. And then it's a bigger task to deal with. And it's really difficult to correct because the bottom has been fused, often with cages. In situ fusion, for a degenerative cause, same issue. Okay, it causes problems. I'm not saying that you will not have problems if you do it perfectly with appropriate angulation, taking into account what has been lost at 5-1, but you will slow the secondary changes down considerably. And those changes will happen regardless due to the mechanics and the biology of the condition. And then there is patient-specific issues, things like osteoporosis. So simple problem, single level problem, single level solution. What can go wrong? Yeah? Well, it can. Osteoporosis. Yeah? Minor trauma, fracture. So when that happens, try and think laterally. Try and not make a small problem or a significant problem into a bigger problem. Try and resolve it and have in your armamentarium ways of dealing with issues, not trying to increase the number of levels that are fused. There's a paper that came out of Salford on impact bone grafting using the same size of screw. It works well for aseptic loosening and cementing done appropriately. Things can go wrong even when you do things appropriately. Infection, we talk about infection. You need to know how to deal with infection. And a patient who came in recently, almost moribund from a deep spinal infection. And till the construct is made solid, the infection can be really difficult to treat. I mean, we can use all kinds of fancy devices with part motion, part not, and etc., etc. But when you have infection, you need to salvage. And then there are surgeon-specific issues. So you have a working dentist who has a bit of back pain, bit of leg pain. The surgery starts. The surgery is carried out, but runs into problems. He has a torrid post-operative time, but he's told that is what he should really be expecting. What did he expect, really? And the surgeon disengages. The patient doesn't want to see the surgeon anymore because he doesn't feel he's being listened to. He turns up, and he's got problems. So you try and rectify it, but often it means not just one procedure. One revision can often result in multiple revisions. But fortunately, he has survived 10 years of this. Then you can have procedures. This is a lady I did, 2014, Degen Scoli, 2 levels, severe symptoms, well motivated, and she did really well for 8 years. And then she developed sciatica. And she has a listhesis at the bottom level, which was completely normal before. So, but now the world has changed. She now has osteoporosis. So what do you do then? So you need to have ways of correcting. So if you look at that, look at the extent of listhesis this is. So you're bringing that back. It's not the same as doing an enterolisthesis. It's a much different beast, if you like. And then you have this kind of problem, long fusion for a single level problem. That in itself is bad enough. It is just a nightmare to deal with. And then if you look carefully, the patient has contractures, hip contractures. You've got to look at the lower limb, get the contractures an issue, because you can't plan it unless you appreciate what the problem is. Whatever you keep doing to them is going to fail. This lady has made an impact on me many years ago. She came to see me. She had a two-level problem. She had aggressive decompression discectomy, simple surgery, yeah. It starts off simple. She's 40 years of age, and now she has a problem. This is post-discectomy. There was no infection. So she has surgery. Now she has a much bigger problem. She has some neurological deficit. She has pain. Wow. So I have revised her, but that is not the end of the matter. This is how things stand, but the top level will go. From my experience and experience of other units that I have looked at when I was a fellow, L3 to S1, it doesn't last. It's a bad combination, and you have to tell your patient, you have to counsel them beforehand. It will require further surgery at some stage. Big units create big problems. So this is from down south. Patient is a judge. Ran into problems soon after surgery. All cages are 0-degree cages. She just didn't feel right after surgery. She couldn't stand straight. She was leant to one side. She was leant forward. And that's, again, I expect further surgery. She has lasted a few years, but she has been counseled. That is a problem. You start off with small, you end up with big. And what we need to realize is that your surgery and this path is full of good intentions. This is a guy, 2006, starts off after a few operations. This is when I got to know him. And infections and CSF leak and all that kind of stuff. And this is how he's ended up. And he would not have had the very first surgery had he known that this could happen to him. This is very real. And his surgery, looking back at his notes, he just had a bit of back pain and a bit of leg pain. This is a guy from Peterborough. But his surgery was not done in Peter. He went all over the place. He had 12 operations. And he's quite active. And he keeps falling on his face and would have he's a retired Air Force pilot. And I looked at that and I thought long and hard. There are areas of his spine that move, there are areas that don't move, and he's had so many surgeries. And I said to him, look, I need to think about this. And it took me 8 months to work out. And the real problem to my mind was the very first operation he had, which was the L5S1 fusion. And I said to him, well, look, I think that is where things went wrong, and that is where I've got to fix you. When you have had a neurological deficit, I tend not to do osteotomies through that area, but he had not had. So that's what he looked like, and that's what I did, which is front, back, front kind of operation. But, and he could jog after that, for crying out. He chased my car in the car park. I was really thrilled to see him. He couldn't really walk properly before. Laminectomy, common operation. Bit of enthusiasm, and then trying to fix it. You know, when you have a problem, I think it's important to try and see, you know, how do I deal with it? Do I have the experience? Do I ask a friend? Do I, you know, or you can just have a go. And having a go has its consequences. All starts with small problems. So this is what she's ended up. She's now 6 years since this. Still okay, but it's important. Just knowing that you can cement a screw in a bone doesn't mean that that is what you do. This is a case from a hospital in London, and you know, cementing into the pedicles is a bizarre thing to do, and cementing into the spinal canal even more, and proximal cementing, it can be dangerous. And then you have the bizarre kind of thoughtful or thoughtless surgeries with consequences. This is a company director, well motivated, absolutely crippled. And you can think about what operation you're going to do. What are you going to do to make him better? God, I thought long and hard. I just took it out. And you know what? He's better than he was before he had his original surgery. He's surviving. He can work. No more surgeries. I was told that I should talk about thoracic as well. That sometimes things can happen in thoracic. Well, yes, they can. Thoracic disc. Well done operation in that the disc was removed, but little attention to the spine itself, and resulting kyphosis. If you take a pedicle out, you take the facets out, you take half the body out, something is going to give. So, I mean, I thought about what are the tips. I could, I think, write a little book on this, but I think there are things to know, that whatever surgery you do, there will be consequences. The longer the fusion, bigger the problem. S1 to L3, in my experience, is a bad set of levels to choose. Tell them they're going to need more surgery, if for some reason you have to consider it. Have other things in your armamentarium: cementing, release, getting the spine balanced, impact grafting. Don't go for a bigger screw, same size screw. And you know, the message that comes loud and clear to me is, often when you look at the original surgery, you question whether was it really needed. And a guy who is in a professional job, who has got nuisance value symptoms, you know, we talk about injections being a bad thing and it costs a lot. You know what? I can have 20 injections, keep the knife away from me, for crying out. I'll go for that. And I think if you're revising, I think mentoring is really important when you're doing primary surgery. And if you're putting implants in, then everybody needs to see in your unit, what are you doing? You know, you've got to know how many screws that you're putting in are not in the right place. Or mechanically, is the construct sound? Simple things, we all talk about it, then how come it happens, and it happens all the time? I mean, I say that because I've had new ones coming to me. So I think something to think about. It is depressing surgery, but I think it's also interesting surgery. It keeps you engaged. Every problem is different. You have to look at it sideways. And yeah, thank you very much.
Thank you, Saeed. We'll welcome to the stage Mr. Nick Hayden. Nick is my neurosurgical colleague at the Royal National Orthopaedic Hospital. He was previously at the South West Neurosurgical Centre before seeing the light and coming to sunny Stanmore. He specialises in minimally invasive work, navigator surgery, and cervical and cranial cervical problems, and is our regional expert in Tarlov cysts and Ehlers-Danlos.
Strike that from the record. Strike that from the record. Thanks very much. It's great to have an opportunity to share with you what I do when I don't get it right first time. And it's great to do it without Mike Hutton in the room, given I clearly don't always get it right first time. We all have to pay for what we get wrong, although some people don't and they leave it to other people. And I actually put this slide up not as an insult, given the unit that I work in and the fact that I do actually see patients from elsewhere, because I actually want to do that. That's what I'm there for. That's what we as a unit in part exist for. But there is a big difference between your own revision and somebody else's. So what pathologies do we see, or what's the etiology behind revision in the cervical spine? Complications at the time of surgery, which I'm going to say very, very little about, because I want to focus on incomplete treatment, recurrence, and what goes on at adjacent levels, both in terms of degeneration and deformity. And I'm going to try to keep it simple to start with and then build, because I don't know in the audience what your practice is like, but I think the same principles can be applied to the complex as can to the simple. So what do patients return with? Well, that's easy. It's the same things as they present with to start with: myelopathy, radiculopathy, deformity, and neck pain. I put this slide in, and some of you will be eye-rolling because you'll guess what's about to come, but to say two important things, and it was already touched on in the first talk, it's a big deal for patients to come back to theatre and to come back to us. And I think we can underestimate that. Not only is the likelihood of a good outcome less with a second operation, or a third, or a fourth, statistically, but it's a big psychological issue. And I think patient expectation, how well they do after surgery, is really important when we're talking about revision surgery. The second thing, that this is the huggy-feely bit, then I'll move on to the surgery, don't worry. The second thing is, we need to, it's the flip side of that, we need to decriminalise when things don't go as perfectly as they should. And some of you will know I'm on a personal mission to remove the word tear from the words dural tear. It's a dural opening which occurs in many operations intentionally, and in some operations, particularly revision, it occurs anyhow, sir, madam. But we've dealt with this and there shouldn't be any consequences, but this is what to look out for. That criminalisation, both of that word and other words, when things don't go as perfectly as we'd like, actually leads, I think, to a psychological burden on the patient, definitely a psychological burden on us, but there are consequences, and there are many private hospitals now insisting a dural opening altogether, is something for which a duty of candour should be undertaken. Okay, I'm off my soapbox briefly. What I've tried to do in what is now remaining about 16 or 17 minutes is look at things that I didn't know when I started doing this 16 years ago, whether it's at the same level, adjacent level, pseudoarthrosis, deformity, and I've mentioned craniocervical instability, but that's an entire lifetime in itself, and with a somewhat dubious interest in the hypermobile patients, most of whom do not need surgery, we know. I'm not going to touch too much on that. But the questions I've tried to answer are the questions I didn't know the answer to historically. Do I need to revise with a cage and a plate? How do I investigate these patients? When do I not operate? Shall I go back in the same direction as the index operation will come from posteriorly if it was anteriorly, etc.? And does it matter whether I come from the same side or not if I'm doing so anteriorly? These are the colleagues coming in from next door. That's how good it is. And ultimately, couldn't resist it. Ultimately, maybe I still don't know the answer to those questions. So let's start and get on with the patient who doesn't get better. They are inadequately decompressed or fail to improve in one way or another. Normally written by the radiologist, and in fact, I can't help but share an anecdote. My favourite ever radiology report was the medical director in Plymouth, who was also a radiologist, who post-op lumbar discectomy wrote a report that said this post-operative scan is absolutely identical to pre-op. I thank you, sir. However, what there is probably an opportunity to do when patients simply don't improve after surgery is say, was it spinal pathology to start with? And you may think, thanks very much, I'm a consultant of X years' experience, I wouldn't miss that, but we all miss it. And could there be a peripheral nerve problem? Could there be a shoulder problem in the upper limb? It's an opportunity to get it right. But we will get it wrong. And this paper shows that 5% of the time, patients who undergo a posterior foraminotomy, we're talking about the simplest of operations here now, nothing instrumented, nothing complex, will actually require redecompression anteriorly for one reason or another, normally because they've been inadequately decompressed. So that's 5%. For those who struggle with maths, or those who've just come straight in from the conference dinner last night, that's 1 in 20. That's a big issue. That is something that means we all probably, unless one person's doing this, end up with a problem. So it will happen. This patient had a relatively straightforward anterior approach, discectomy, fusion for radiculopathy, and had persisting symptoms afterwards. It's an opportunity to find out how we can improve things. And what I would suggest and commend to you is a standard MR doesn't really, or quite often, it is difficult to tell whether or not the patient's foramen is as open as you'd like it to be. And even on the parasagittal scans, it can be difficult. And so I would commend to you, and I apologize if you're all already doing this, but I certainly wasn't when I started as a consultant, I would commend to you the value of the parasagittal oblique in any revision operation to actually look in detail along the line of the nerve root, where I think, and I hope that projects as well as it needs to, and I promise you it does here, you can see the root and see whether it's compressed or not. I have both undertaken surgery I otherwise wouldn't and avoided surgery historically as a consequence of using those. And for any revision or any difficulty in foraminal assessment, for me, that is the go-to. And just to share, it was the paper at the top that I read in 2009 and thought, oh, look at that, I'm up to date, I'm going to start doing parasagittal obliques. And then I realized that actually it was published in 1987, and I must have missed that bit in my training. Okay, so we've got a patient who's got a radiculopathy which hasn't improved. Irrespective of which way you came, which way you're going to solve the problem, well, we've looked at a patient who had an anterior approach, and I would suggest that I'd rather come from the unsullied direction. I would rather do the opposite if that's possible. I would rather wait, allow the patient to fuse, and then do a posterior operation if at all possible. Mainly because ultimately revision anterior approaches are more challenging if it's not the, if the anterior was the index operation. More challenging the second time round. Even when it's straightforward, it's more challenging than it would have been. There will be occasions where we need to reapproach acutely anteriorly, or indeed to decompress posteriorly without fusion having occurred. What about myelopathy? Well, this is a particularly unexciting scan. It's a typical patient that we'd see in all our practices, no matter how specialized we are. We still see fairly routine patients. Sometimes she's an elderly lady with 3/4 listhesis, and concordant myelopathic symptoms with her radiological changes. And you won't be surprised to see that what we offered her and what she had was a fusion. But then post-operatively, she was still progressing. And I would say that it is rare after anterior surgery to see progressive myelopathy because of persisting anterior compression. It is far more likely that there's posterior compression which may electively have been avoided in the hope that anterior would be adequate, proven not to be, and need to be approached again posteriorly. But it does happen, and an anterior revision approach, as we've said, a more difficult operation than the primary operation, and in the presence of neutrality of the alignment or lordosis, perfectly reasonable to go posteriorly for your subsequent decompression if that's needed. Probably not a great idea if there's kyphosis. To leave no stone unturned in this lady, and again, this is just sharing another modality which you may all be sat there thinking we use this every day, but I didn't historically, because in the deepest, darkest southwest we didn't have it. We use flexion extension MRI to demonstrate that the very thing I've just talked about, that posterior compression, isn't there when the patient's in the extremes of extension, and you can see in this patient's case she wasn't. This I've shared as a primary case just to show how convincing it can be. It's a young lady with a combination of lower limb symptoms that could have been radiculopathy from her lumbar changes, which I haven't shown you, or could have been myelopathy, but it was unconvincing, and certainly radiologically unconvincing on the primary supine neutral scan on the left, but I think the extension scan is pretty convincing. And certainly that's someone I wouldn't have offered cervical surgery on historically without the flexion extension. So what happens when the adjacent level is affected after we've done surgery? So they do well to start the bit, the patient does well, but then they get adjacent level changes. Most senior registrars can quote the Hillebrand paper. It's one of the few papers everyone ever learns. And we know that adjacent level changes will occur, but we also know that they don't require intervention anywhere near as often as they occur. They're more often radiological rather than clinically relevant. I'm going to change the bottom of this slide at some point from what I've learned in the last 3 days. And you're all thinking, hang on a minute, someone's learned something in the last 3 days. I think we probably all have. I hope we have. I've realized that I think the evidence is gathering that in a specific cohort of patients, in the long term, there might be some advantage in motion preservation. And what do the patients present with? There's nothing stunning there. It's the same things they present with anyhow. And I'm going to use this next patient, you're going to see her for the next 4 or 5 minutes, as a vehicle to explore what we can and should do when we're considering revision surgery. She first had her ACD at the level you can see for myelopathy long before I was anywhere near her in the early 2000s. And did very well from it. She developed subsequent superjacents, or C3-4, with a normal intervening level. Subsequently, in the late 2010, 2011, and my predecessor fixed that level and improved her myelopathy, or at least prevented its deterioration. Some of you will be looking at that thinking, why they left that in the middle? Number one, I told you it was my predecessor, not me. And number two, I would have done exactly the same. And I'm sure there were people in the audience saying, well, there's an inevitability that's going to progress. I'm sorry, but show me the crystal ball. You'd be right, but that's not the point. We don't know that that's going to progress. Is it the right or wrong thing to do the intervening level? Who knows? But at least this lady's now got 3 different versions of anterior interspaces. She's fused. Her myelopathy at that point was relatively controlled and certainly not progressing. She's the prime example of someone who, in a repeated fashion, needed to come back. And would you consider that anterior or posteriorly? I think my gut feeling is most of us probably would have continued to do that anteriorly, but why, and is it an issue? It's probably not an issue if you consider each operation as a primary operation, which I think at a different level, it kind of is, particularly if you do it through a new incision. It's very frustrating when the previous surgeons put the incision high and you want to go even higher. But if that's not the case, then actually I think that's it's effectively a primary operation. But I would consider the consequences of the previous operation, including hoarseness and swallowing problems. Recurrent laryngeal nerve problems occur far more often than we realise, a few percent in primary surgery and up to 10% in revision. If you've already got symptoms, it may be that the anterior isn't a great approach. Do you come from left or right? Probably best we debate this later. I think that is a trade-off between reapproaching and something being better in your hands in the way you regularly do it. I'm a right-sided approach surgeon, that's what I always do in the cervical spine, and I think I've done one left side ever. I've got colleagues who will go from the opposite side to the worst foraminal compression, which is a new thing on me. I just walk around the table, but maybe I'm simple. What are the issues anteriorly? Do you remove the plate, don't you? Well, if you can get away without doing so, it's pretty obvious, don't do so, and that's saw the birth of all of the integral plates. But there are issues with increased dislocation, and I think far more significantly increased subsidence with some of the integral plates. I consider corpectomy, but in my hands, much as I love doing a corpectomy, I'd only do it if I absolutely needed to, and there's compression behind the vertebral body. I don't understand the reason for that in revision surgery otherwise. And again, I actually had a conversation during coffee with one of my colleagues about the fact that every now and again an ENT surgeon really is needed for your approach, not normally in a revision at the adjacent level, but where there is deformity as well, or many recurrent operations. And I'd recommend, as we did in our conversation, that it's probably a head and neck cancer ENT surgeon who's going to be the best person to help you with that in that setting. So back to our lady who's had 3 levels done, and now she represents at the stage I meet her with progressive myelopathy. She has this scan, she's got myelomalacia. Is that relevant? The literature would suggest that it might be relevant in the in the primary setting, but we know it's probably most directly linked to the number of levels of compression, and the duration of that compression, and that's why actually in the tumour setting in the thoracic spine, I was hoping my colleague was going to be here, but he's not, because he was very excited the myelomalacia had disappeared in this patient. In the acute setting, when it's not been there for very long, it will often go away. But is it relevant whether it goes away or not and the patient gets better? Who knows? This lady, attempting to blame her progressive myelopathy now, which she's represented 10 years later on the myelomalacia, but every MRI she had got this little nubbin of something possibly pushing on the cord, which none of the radiologists, always happy to come off the fence when it's criticising the surgeons, but not when they don't want to, say, well, it might be artifact, it might be real. The CT was equivocal, and so I again commend to you one more radiological investigation that I'm sure we all use, but just remember the CT myelogram. It's invasive, but less invasive than surgery, and that reassured us that this lady's appearances on the MR were actually artifactual. And of course, it's of value in those who can't have an MRI scan. Briefly, we know after posterior surgery, which tends to fuse well, but we know that adjacent level changes occur normally in the superadjacent level. How do we treat that? Well, in the absence of instability, and maybe, unlike the patient I've just shown you, the patient simply has a foraminal disc at the level above, then maybe it's reasonable to treat that as a primary operation and do a posterior operation, do the same thing you would. All I would say is the evidence for posterior foraminotomies nearly all pertains to the primary surgery, not revision surgery. And you do have that challenge of whether or not you'd still consider a fusion, given the patient's had previous surgery. Ultimately, if they've got pain, radiculopathy, and myelopathy, I think I'd counsel going anteriorly. Symptomatic pseudoarthrosis, the important bit, and I put this down so that I didn't forget, we all know it, but it's symptomatic. It doesn't matter if they've got a pseudoarthrosis otherwise. Well, it doesn't matter to me anyway, I don't care. I can't make them better than they are, they don't get an operation. Back to the gift that keeps on giving, this lady who's had 3 anterior operations, still has myelomalacia, still deteriorating neurologically. We don't think there's a cause for it or anything we can identify, but she's got terrible neck pain as well. We know that in single level ACDs, 20% don't fuse, and 2/3 of that 20% end up with pain. It looks like she's probably not fused at the 2 superior levels here. We certainly couldn't convince ourselves that it had. Flexion extension x-rays may be useful with posterior instrumentation. In particular, haloing, although we see it anteriorly as well, is of use. And our go-to in Stanmore is definitely a SPECT CT. And you can see here that this lady has got increased uptake, which she frankly shouldn't have 10 years down the line, but only at one of the 2 levels where we thought she hadn't fused. So, of course, we fused both of them. And in this setting, again, you could go anteriorly, posteriorly, or circumferentially. I would avoid posterior surgery if the patient's been decompressed already because of the exposure of the dura, and that's someone who's very happy opening, not tearing the dura. An interesting observation in a number of studies is simply instrumentation posteriorly will lead to fusion anteriorly, even in the absence of it over a long period of time. So you may not need to worry about that fusion bed posteriorly. And of course, if the patient's had a pseudoarthrosis, it's time to get on top of the modifiable factors, the most obvious one being smoking. How do we prevent it to start with? Prevention is always better than cure. End plate prep. Do we use a plate or not? And fusion material, there's another entire lifetime of work, so I'm not going to say much about that. I just want to comment on the plate, because it was one of the questions I had to myself when I started this process. Ultimately, up to 2 levels, all the evidence suggests that a plate leads to less subsidence, quicker fusion, but absolutely no different in clinical outcome. But that may not apply in revision operations. Okay, as we sort of come towards the tail end of this now, we're going to go and look at a couple of things that are a little bit more complex. This clearly isn't at the moment. This is a kyphotic deformity from a post-laminectomy, in a post-laminectomy patient. We know it occurs most commonly with posterior surgery, although it can occur with anterior, and it affects both the coronal and sagittal plane, though it's the sagittal plane that has the most consequence. It occurs in patients who are elderly, where the facet resection is aggressive and where there's pre-existing kyphosis. X-ray will tell us whether or not it corrects, and if it does, our life has just become a whole lot easier. CT will tell us when it doesn't correct, whether it's fused at the front or the back or both, and MR will tell us whether or not there's ongoing neural compression. And once again, you can treat this anteriorly, posteriorly, or circumferentially. If there is no anterior compression and the deformity corrects on a flexion extension radiograph, no reason not to offer the patient posterior surgery. If it's a fixed focal kyphosis and there's no dorsal fusion, an anterior approach may well be the best option, and multi-level ACDs are probably preferable to a corpectomy in this sense because of the opportunity to correct that deformity at every level. The studies would suggest that the chance of a non-union with multi-level ACDs is greater than with a corpectomy, but with a corpectomy, you've now got a potentially unstable anterior construct and would probably want to fuse posteriorly as well. So these are all things to be considered. This is not a one answer all. Brief comment again on prevention. If we're going to do a laminectomy, many of you will do laminoplasty. Many of you will always fuse when you do so. I would commend the split or skip laminectomy that I learned as a fellow in Leeds, and which I think is a great way of decompressing without disturbing the posterior elements any more than is absolutely necessary. Okay, finally, 2 patients to consider who are definitely at the other end of the spectrum, both on my current waiting list. The first is a 62-year-old achondroplastic who's had multiple operations, but ultimately it's those last 2 that interest us. He's had his cervical spine decompressed and fused and then extended for initially myelopathy and then progressive kyphosis. And this gentleman is in a wheelchair. His legs haven't worked for a very long time, and he's now losing use of his arms, as well as a consequence, presumably, of those appearances on the MRI scan, where his cord is draped, compressed, and frankly, how anything's working, I'm not entirely sure. If you look at the X-ray, you can see he's got broken screws. The screws are pulled out of the occipital plate, and I haven't shown you the CT, but he's got some lucency around some of those lateral mass screws as well. He's pretty cheesed off, and I have to say I was at first sight very tempted to say what the surgeon who'd sent him to me said, which was no thank you, because I think the chances of making him worse are high, and that's where counselling the patient comes in here. I think the chances are extremely high. However, he's in a lot of pain, and whilst it's tempting to look at that and think, well, if we took the posterior metalwork out, could we correct him anteriorly? What you can probably just about appreciate, and you can when you meet him, is this man has no neck. You will not get into, well, you're welcome to try, but I'm not going to try to get into the front of his neck because it's just not going to happen. So probably the best option for him is to look at replacing that metalwork posteriorly, because he has pain from the non-union. And find new bone, in other words, rediscover the pedicle that exists between C3, 4, 5, and 6, which when I was growing up didn't exist, and instrument into something that hasn't yet been sullied posteriorly. My plan is to do that. Not quite sure what we're doing with the occipital plate, but we'll be changing the type of plate and putting the screws into somewhere else where there is enough bone to do so in his occiput. And then I'm probably going to stop. I'm not going to decompress that cord unless he continues to deteriorate, because I think the chances of making him a lot worse are high. 46-year-old man with DeGorge syndrome, previous OC fusion, 3 endoscopic decompressions of his sphygmomedullary junction for myelopathy, and was sent to see me at Stanmore because the rods are broken, he's kyphotic, he's in pain. He feels he's also getting a little bit worse. This is his scan after his last posterior operation. And you can see that I hope you can see there that there's plenty of space, whereas now, that looks awful. That is actually the peg out lateral, that's the midline. So actually his neural structures, and we're still waiting for an MRI, are probably still decompressed. But what you'll see, if I take us to the money shots and then share that with you, is he's actually simply broken his screws, he's not fused, he's got a combination of a coronal and sagittal plane deformity, and he's in agony as a consequence of it. I think there's little choice but to offer him revision surgery, and again it's a case of saying, well, what do we do that is better than previously? We can't go anteriorly because he's had 3 operations anteriorly, certainly at 0, 1, 2. I have no desire to go there, and I think it's a case of using what didn't exist until navigation. I don't think the pedicle existed at 3, 4, 5, 6, but it most definitely does now, and that's fresh territory that we can try and make sure we instrument him adequately, change his rods to cobalt chrome, and then pop him into a halo ring and vest and tell him never to take it off. Well, certainly not for quite a long time, anyhow. This man tells us we've always got to do something, mustn't hang around doing nothing. We as surgeons know that's not always the case, and I just want to share the other side of the coin with you after this rattle through. This was a patient who, ironically, was referred to me from London because he lived in the southwest when I was still working in the southwest. He fell down the stairs of a double-decker bus, had a hyperflexion injury, had a facet fracture, perched on one side, fractured on the other. And by the time I saw him 6 months after this injury, he had terrible neck pain, weakness in the appropriate side that you can see on the top left image where that fragment is sat in the foramen. Weakness and pain, weakness of elbow extension, and pain shooting down the back of his arm. So I looked at his imaging, and I was impressed with the AP plate, which rarely looks quite as good as that. It's always drifted off a little bit, hasn't it? But I was less impressed with the lateral, which I was slightly surprised to discover that the only disc work that had been done was putting 4 of the screws in the plate into the disc, and there doesn't appear to have been, maybe it's unfair to say there's no attempt to, but certainly hasn't been even remotely reduced. And he was in quite a lot of pain. We did an MRI scan. I didn't do parasagittals at that point. I was fairly convinced that he'd got ongoing compression, and of course I offered him an operation. And he thought he knew better than me, rude, and said, no thank you, I think it's going to get better. And it just goes to show he was right, because a year later he came back to see me with no neck pain, arm pain gone, completely resolved, delighted, not with the year's delay, but delighted with the final endpoint. And I'm still considering whether I write to the primary surgeon and ask him to write this up as a novel technique. Probably not. So in conclusion, I have rattled through things there, but tried to share with you the fact that we can apply the simple principles all the way through revision surgery, wherever it is, but certainly in the cervical spine. I've shared with you some imaging modalities which you may all use, but I certainly didn't historically, and now they are my go-to in many ways. Do the operation the patient needs, not necessarily the one you can do. And that, I think, means if you're not familiar with it, find someone who is, or find someone who's more familiar with it, or discuss those complex cases. We're all learning, and we all get things, we're not allowed to say wrong, are we? Suboptimal. Problems will occur in our own patients and others. Prevention is definitely better than cure, it always is. And to reiterate, these patients are suffering, they're coming back for revision surgery. For us, it's a technical procedure to some extent, but for them, it's very emotive, and I think counselling them is appropriate. And let's decriminalise where possible, because you never know, it's going to be you next. Thanks very much.
Thank you, Nick. Two excellent whistle-stop tours through a highly complex area of our workload. We're at the end of the allotted time, so feel free to leave if you need to, but I think we should take the opportunity, I didn't mean you, obviously. I think we should take the opportunity to use our faculty. If people have questions, please feel free. And Aprajay's leapt to the front. Go ahead, sir.
Fascinating, like always, you see. Nick, question to you about the CT SPECT. When we start doing it, we've had fantastic, we have got something. But then came across few cases where the CT is showing a solid fusion 5 years down the line, and the SPECT is positive. What's happening there?
Well, you know I'm not going to answer that in terms of giving you an answer per se, but it's interesting, isn't it? I've moved to a unit where it's the go-to for lots of things, and I think it is very useful. It clearly is not absolute, and in the patient I showed, there was high uptake at one level, but unequivocally on the CT anyhow, say unequivocally, no fusion at that upper level. So I don't know. I think it's just an additional tool. I don't think we can rely on it on its own. And I actually, even last night, was still trying to find some convincing evidence for it in the cervical spine and revision surgery, and couldn't. Messaged one of my colleagues who's a bit advocate saying, you know, what's the literature evidence? And I've still not heard back. So I think the jury's out a little bit.
Can I ask you, Saeed, you implied throwaway line maybe, but we maybe need a complex database to collect the data on this. And obviously we have the registry, but that is reliant upon us putting in revision surgery as exactly that. And I think it may be worth looking at the registry in terms of what do we have presently. And Rob, we were talking about this beforehand, but what do you mean by that? What would you like to see?
So I'm very specific in that unless you ask the right question, you will get gobbledygook answer which isn't worth it. You're playing with numbers, and numbers, stats will show you anything you want them to show you, okay? So just take, for example, fusion, cervical spine. The way my practice has developed is I'm a plater. But when I plate, I lordose that segment. Mm-hmm. I look at the overall alignment, number one, okay? Is because you get more problems. So if you are going to look at fusion, then those parameters have to be fed in, because otherwise, you know, your plating in kyphosis is not the same. You know, you've got to compare like with like. Mm-hmm. And I think that level of data has to be collected. The numbers we are looking at are not huge. And that is why I suggested, you know, a PhD or somebody like that to really invest into that, because people just, you get an impression of having a go. So for example, my cervical spine surgery has evolved. I don't do more than one level fusion for degenerative conditions. So I'll do a front for one, I'll choose, and I'll do posterior, but I do a lot of ligament reconstruction. So because I have inherited a lot of two-level fusions with chronic neck pain, all right? Mm-hmm. You get chronic neck pain when you have two-level fusion, and you get even more pain when you have three-level cervical spine fusions, okay? So, I mean, like the achondroplasty you showed me, I've got a patient that one of my colleagues here asked me to look at, who had laminectomy, young lady, head is right off, and cord was a ribbon, and she has symptoms. And I did one level anterior, and I reconstructed the ligament at the back, and she has many, many years down the line, and she has retained the motion. So you can convert that, but how do you get that? Is by looking with the right lens, right question. So it's not just the question of just collecting more. Is what is it that you collect, and then somebody to really analyze it properly from that respect.
I mean, I think we should perhaps look at that from within BAS with the new incoming BSR people and look at what data we do have to inform that next step.
Yes,
but
yes.
You're absolutely right. The registry won't give us the answer to
No.
that because of the data input quality.
Sorry, Shah Halim from ROH Birmingham. As a group, is there something, one of the speakers touched upon this, the scaremongering from the reports of radiologists, and apologies to any of our colleagues in the audience, is there anything BAS can do as a group to get a better quality report without all the grief that comes from reading the report? Because the patient gets a copy of the report, and they always come and talk about the multiple levels of, disc prolapses and all sorts of things, urgent neurosurgical opinion advised and blah, blah, blah. So is there something that we can do to let our radiologists know that the report quality needs to be less, worrying for the patient, and this keeps to the point?
So can I ask you to answer that specifically? What I would say is I was involved in the BOAST, so the BOA trauma document for clearance of the cervical spine. And it was one of the first times, I think, where the spinal societies managed to coerce radiology into using specific terms and phrases, for example, very specifically to clear the cervical spine. So I think it is achievable, but this is a much more complex scenario. So what are your thoughts, Nick?
Yeah, this is close to my heart because I often, as I did, say that reading that report from our perspective is sometimes unhelpful, let alone the patient. I think you've touched on two things. One is, can we get our radiology colleagues to use specific terms in specific settings to answer specific questions? And then the other is, how do we stop patients who are allowed to see everything, seeing their report until we are there to counsel them appropriately and put it into context? Because it is unequivocally a problem. And if you look at patient expectation and its links to outcome, and particularly, many of you will have heard me say this before, but we're actually not in the evidence-based medicine game in much of what we do in the spine. We're in the patient satisfaction game. And unfortunately, if the expectation is set on the basis of reading a radiology report, I think we've got real problems. I've got 2 trainees at the moment who are at the beginning stages of looking at whether we can put something together to look at the psychological impact of patients reading or not reading their report before they come to clinic. Whether that will be a big enough outcome to bash anybody with, I don't know, but I do think we need to take that forward.
So I spoke at a meeting a couple of weeks ago at the British Skeletal Radiologist Society meeting, and they were very receptive to dialogue along those lines. So I think if you can inform that decision with something like that evidence, I think that is something that BAS could take up with the SBNS as we work very closely together anyway.
Okay.
So,
I think Raja is saying we have to move on to the next session. He's giving me the cut sign.
okay. So thank you very much for your attention, and thanks to both speakers.
Thanks so much.